Good morning. Our session today is about the extrapyramidal system. What is meant by the extrapyramidal system? It is a neural network located in the brain that is part of the motor system. The motor system is formed of the pyramidal pathway, which is the corticospinal and some corticobulbar tracts, that may directly innervate the motor neurons of the spinal cord or brainstem. Whereas the extrapyramidal system centers around modulation and regulation, the indirect control of anterior horn cells. So we have two systems or two pathways that control the motor activity of the body. We have the pyramidal pathway, which directly innervates the motor neurons, and we have the extrapyramidal pathway that modulates and regulates the anterior horn cells. What are the functions of the extrapyramidal system? We have physiological functions, which are realization of the automated motions, myostatic regulation, regulation of pose, and regulation of muscle tone. To understand better these functions, we have to know what happens if this function is impaired. So, our first function is regulation and integration of voluntary motor activity. What happens if this function is impaired? We have involuntary motor activity, which is either rhythmic and regular, forming static tremors, or dysrhythmic and irregular, giving chorea, athetosis, and dystonia. So, this function of the regulation and integration of voluntary motor activity can give involuntary motor activity, which is either rhythmic and regular or dysrhythmic and irregular. The second function is regulation and maintenance of the muscle tone. The dysfunction of this ability gives hypertonia or rigidity. Hypertonia in affection of the extrapyramidal system is formed of rigidity. What is rigidity? Rigidity is stiff movement all over the movement from the start till the end of it. It can be a smooth rigidity, which we call lead pipe, or it can be interrupted by tremors, which is cog wheel. This is different from the type of hypertonia that we find in the pyramidal system, which is called spasticity. Spasticity is present at the beginning of the movement, and then there is let over in the rest of the movement, which we call clasp knife spasticity, with initial resistance and then let over of movement. We have then the next function is regulation and maintenance of emotional and associative movements. And if this function is impaired, we have bradykinesia, which is slowness of movement all over the body, masked face with no emotions, infrequent blinking of the eyes, loss of swinging during walking. We have swinging of arms during walking, which is an automatic movement found in all individuals, and this function is impaired in extrapyramidal system affection. What are the structures that belong to the extrapyramidal system? The first one is the frontal cortex, the cortex of the frontal lobe of the brain. Then we have the basal ganglia, which are the corpus striatum, caudate nucleus, lentiform nucleus, which consists of putamen and globus pallidus, medialis and lateralis, substantia nigra, subthalamic nucleus, and red nucleus. There is the reticular structure or reticular formation of the brainstem with many connections between these structures. The anterior horn cells and at last the muscles. The structures of the basal ganglia connect to the opposite extremities, opposite side of the body. So the main structure here of the extrapyramidal system is the basal ganglia. These are the structures forming the extrapyramidal system. First, we have the cerebral cortex, the frontal part of the cerebral cortex. Then we have the lentiform nucleus with its two parts, the putamen and the globus pallidus. We have the caudate nucleus. We have the subthalamic nucleus below the thalamus. We have then the substantia nigra and the red nucleus, with the many connections that we see here between these parts of the extrapyramidal system. Then the tracts then descend to supply the anterior horn cells, which gives the muscle at last. This is another picture of the extrapyramidal system and all its parts. We can see here the cerebral cortex, the basal ganglia. Okay. There are two main parts forming the extrapyramidal system, the paliostriatum and the neostriatum. The caudate nucleus and the putamen belong to the neostriatum, while the globus pallidus, red nucleus, substantia nigra, subthalamic nucleus belong to the paliostriatum. Affection of these two parts of the extrapyramidal system gives a different picture, and there must be a balance between them. The neurotransmitter or the mediator of the paliostriatum is the dopamine that is synthesized in the substantia nigra, and the mediator of the neostriatum is acetylcholine. Paliostriatal syndrome. We said that the neurotransmitter in the paliostriatum is dopamine. Loss of dopamine neurons in the substantia nigra is one of the main pathological features of Parkinson's disease. So, the important points that we have to take care of here is that the paliostriatum has dopamine as a neurotransmitter, and its affection results in Parkinson's syndrome or Parkinsonism. The symptoms of this disease do not show themselves until 80 to 90% of the dopamine function has been lost. This neurological syndrome is characterized by tremors, hypokinesia, rigidity, and postural instability, and we are going to describe each one of these separately. First, we have tremors. Tremors of Parkinsonism are resting tremors that occur at rest, not with movement. It's classically seen as pill rolling action of the hands. There is pill rolling of the thumb against the fingers. It's a continuous movement that occurs at rest and disappears with movement. It may also affect the chin, lips, legs, and trunk, and can be markedly increased by stress or emotions. We have then hypokinesia, or slowness and diminished movement. The movement of the body is slow and diminished in amplitude. And there is also bradykinesia, which is slowness. So there is hypokinesia and bradykinesia. Rigidity, as we said before, we have either lead pipe or cogwheel. The difference between them is the presence of tremors. If there are no tremors, so we have lead pipe, which is smooth, rigidity all over the movement from the start till the end. And if the rigidity is interrupted by tremors, we call it cogwheel. And we know, of course, that rigidity occurs when we move the limb passively. It's with passive movement. The last one is postural instability that leads to impaired balance and frequent falls. Other names of Parkinson's syndrome is hypertonic-hypotonic syndrome and akinetic syndrome. Okay, what are the gait and postural disturbances that occur in Parkinsonism? We have shuffling gait. Shuffling gait is formed of short steps and the feet barely leave the ground. The feet are always touching the ground, so it gives us the shuffling noise that we can hear clearly in Parkinsonian patients. So they are short steps with shuffling noise. There is decreased arm swinging, which is the automatic movement that occurs during walking is decreased. Stooped forward flexed posture. The patient is always flexed anteriorly, and in severe forms the head and upper shoulders may be bent at 90 degrees relative to the trunk. Propulsia or propulsion. Propulsion is a tendency to move forward, and the patient cannot stop himself. Festination is a combination of stoop posture, which is leaning forward, imbalance, the patient cannot maintain his balance, and short steps, which leads to a characteristic gait that gets progressively faster and faster and often ending in a fall. We have gait freezing, which is a manifestation of akinesia. The patient cannot initiate a movement easily. There is difficulty in initiation of movement. And in late cases, there is inability to move. Gait freezing is characterized by inability to move the feet, which may worsen in tight, cluttered spaces or when attempting to initiate gait. All these gait and postural disturbances we can see in a specific example, which is when a person is trying to get the bus. First, he sees the bus and he's trying to move to get on the bus. He has difficulty in initiation. There is gait freezing at first. Then the patient starts to move. His movement is slow at first, then becomes faster with the tendency to lean forward. When the patient gets by the bus and is trying to get on it, he tries to stop to get on the bus. Then he is unable to stop and falls down. This picture can summarize all the gait and postural disturbances that occur in Parkinsonism. Speech disturbances. We have monotonous speech. Monotonous speech is slowness of speech without change in tone. There is automatic changing in tone while we talk so that others that are hearing us do not get bored. When you hear a Parkinsonian patient, there is a monotonous speech with slowness. There is also drooling of saliva, because such patients have difficulty in swallowing. Saliva flows outside the mouth, most likely caused by weakness and infrequent swallowing and also stoop posture. Masked face. There is mask-like face, also known as hypomimia, with infrequent blinking. There are no emotional, the emotional fibers of the face are not working well, and the patient is as if he's wearing a mask. There are no emotions while he's talking. Difficulty rolling in bed or rising from a seated position. The patient cannot roll in bed easily because of spasticity of the whole body, rigidity of the whole body. There is micrographia, which is small cramped handwriting, impaired fine motor dexterity and motor coordination, impaired fine motor coordination. There is slowing of mental processes. There is repetition of questions, and the patient finally has a hunched back or due to leaning forward continuously. This is a picture of a Parkinsonian patient, and these are all the manifestations of the Parkinson's disease. There is a stooped posture, masked face, rigidity of the back, actually it's of the whole body. There is flexed elbows and wrists with reduced arm swinging. There is forward tilt of the trunk. Hand tremors that we said are resting, pill rolling tremors that disappear by movement. There is slightly flexed hip and knees, tremors of the legs, and shuffling short steppage gait. How do we treat Parkinsonism? First, there is physiotherapy to relieve rigidity. There is speech therapy to improve swallowing and speech problems. Diet advice. Parkinsonian patients also have constipation. So we have to advise them to get increased amount of fluids and fibers in diet. The medications that we use in treatment of Parkinsonism are L-DOPA or levodopa, which is converted to dopamine in the body. We have dopamine agonists. We have MAO-B inhibitors, COMT inhibitors. Surgical treatment, mainly deep brain stimulation. and treatment of associated symptoms like depression and insomnia. So, to remember the treatment of Parkinsonism, we have to search for functional impairment at first. If we don't have functional impairment, so we don't need pharmacological treatment. We use non-pharmacological treatment. As we said, group support, education in the form of speech therapy, physiotherapy, exercise, and nutrition or dietary support and advice. Okay, if we have functional impairment, we need also the non-pharmacological treatment plus pharmacological management. Pharmacological management depends on the severity of tremors. If they are not severe, so we use levodopa or dopamine agonists or amantadine, which are quite enough in such patients. Or if tremors are severe, we use anticholinergics or L-dopa or dopamine agonists or amantadine. If they are inadequate or the response is poor, we shift to deep brain stimulation. So this is to summarize the treatment of Parkinsonism and how to approach treatment. We have to think of the symptoms, the presenting symptoms of the patient, and according to these symptoms we give treatment. Okay, so we finished the paleo-striatal syndrome. Now we have the neo-striatal syndrome, which is called hypotonic hyperkinetic syndrome. Hyperkinesia here is involuntary, irregular motion. There are several types of hyperkinesia. We have atitosis, which is dyskinesia characterized by inability to maintain fingers, toes, tongue in a stable position, resulting in continuous, slow, sinusoidal and flowing involuntary movements. Atitosis, we say that it's like snake-like movements that affects the fingers, toes, and tongue. Chorea. Chorea is the most common that we see and the most important. It's characterized by brief, irregular contractions that are not repetitive or rhythmic. So, they are not rhythmic. This is very important. It's brief, we say shock-like, irregular contractions that are not repetitive or rhythmic. They appear to flow from one muscle to the next. So, they are dance-like. These patients have a specific gait called dancing gait because of this brief irregular contractions. And when it affects the extremities, especially the hand, we have piano-like sign. The fingers are flowing or moving in a piano-like movement. Okay, so these are dance-like movements from the same root word as the choreography. It can be the sign of rheumatic fever. Chorea, we have rheumatic chorea or Sydenham's chorea, which is the most important type of chorea. Okay. What are the causes of chorea? There are many causes, but the most important that we have is Sydenham's chorea and Huntington's chorea. What are the other types that we have? We have drug-induced from levodopa in Parkinson's disease, oral contraceptive pills, and some psychiatric drugs. We have vascular disease of the basal ganglia, like atheroma or systemic lupus erythematosus, SLE. As we said, Huntington's disease, which is a degenerative disease, post-infectious, Sydenham's chorea, and thyrotoxicosis. The first and most important is Sydenham's chorea. It's the most common cause of acute chorea in children. It occurs with acute rheumatic fever, so we call it Sydenham's chorea or rheumatic chorea. It's a complication of group A beta hemolytic strep infection. That's why we said that it is post-infectious or due to infection, due to group A beta hemolytic strep infection. It starts at the age of 8, more in females. It is treated with valproic acid, neuroleptics, intravenous immunoglobulins, and steroids. This is how the patient looks like in chorea. Sudden, shock-like movements that are irregular and not rhythmic. Okay. The next important type of chorea is Huntington's chorea or Huntington's disease, which is an inherited disorder. There are two main symptoms of Huntington's disease. These are progressive mental state changes and choreiform movements. So the patient has choreic movements and mental changes. The inhibitory neurotransmitter GABA is depleted in the basal ganglia and substantia nigra. So Huntington's disease occurs due to depletion of GABA in basal ganglia and substantia nigra. There is no effective treatment to prevent or delay progression of Huntington's disease. And there is an important point is that with progression or with when Huntington's disease goes into generations from father to son to grandson, there is anticipation of the gene, which and the Huntington's disease occurs at an earlier age in each generation. We can give symptomatic treatment of these choreiform movements like antipsychotic drugs, but there is no specific treatment for Huntington's disease. Dystonia. There are many types of dystonia, but what is dystonia? Dystonia is painful, prolonged muscle contraction that results in abnormal movements and posture. Okay, so we have very important words that have to be memorized. It has to be painful. Dystonia is always painful and prolonged, to differentiate it from hypocalcemic spasms, to differentiate it from other types of muscle contraction or involuntary muscle contraction. It has to be painful and it has to be prolonged. And it has to result in abnormal movements and posture. So painful, prolonged, abnormal movements. This is dystonia. This is the triad of dystonia. Okay, what are the types of dystonia? We have oromandibular dystonia or Meigs syndrome. Dystonia affecting the muscles of the mandible and around the mouth. So it affects the lower facial muscles and jaw muscles, causing involuntary opening, closing, or deviation of the jaw, and the tongue may be also involved. So this is oromandibular dystonia, and from its name, oro denoting oral cavity and mandibular denoting the mandible. So it affects the lower half of the face. The other type of dystonia affecting the facial muscles is blepharospasm. Blepharospasm affects the muscles around the eye, causing involuntary contractions of the muscles around the eye that causes excessive blinking and spasm of eye closure. And in late cases, the patient cannot open his eye. We then have cervical dystonia or spasmodic torticollis. It affects the neck muscles, leading to abnormal movements of the neck and head. So it affects the neck muscles, causing abnormal movement of the head. Spasmodic dysphonia or laryngeal dystonia. It affects the laryngeal muscles and vocal cords, giving strangulated hoarseness, strangulated voice, hoarseness of voice, and maybe whispering. The patient cannot talk normally. He has strangulated voice with hoarseness and whispering. So we have two types affecting the facial muscles, the oromandibular dystonia and blepharospasm. We have two types of dystonia affecting the neck or around the neck, which is cervical dystonia or spasmodic torticollis and spasmodic dysphonia or laryngeal dystonia. We have two types affecting the limbs, which is limb dystonia, causing cramping or spasming of the legs or feet. These are affecting the lower limbs, and we have also limb dystonia affecting the upper limbs and might be associated with writer's cramp. There is cramp of the muscles of the hand whenever the patient tries to write something. Limb dystonia, writer's cramp, and musician's dystonia. Involuntary movements, cramping and spasming of the hands or arms, which can be brought on by repetitive and task-specific movements. Task-specific here refers to writing or playing a musical instrument. Okay? So we have these different types of dystonia. We are going to describe these types more and with more types of dystonia. Okay, we have hemiplegismus. Hemiplegismus is a rare type of dystonia characterized by wild movements of the upper limb when the patient tries to move. It has abrupt onset and can be following hemorrhage, infarction, or damage of the subthalamic nucleus. يبقى hemiplegismus affects the muscles due to subthalamic nucleus affection. Torticollis, as we said before, there is head tilt towards one side. The chin is elevated and turned towards the opposite side. The head is typically tilted in lateral bending towards the affected muscle and rotated towards the opposite side. So torticollis is dystonia of the muscles of the neck, which causes head tilt towards one side, and the chin is elevated and turned towards the opposite side. We find the head in a lateral bending position towards the affected muscle. So there is a specific muscle affected, and the head is bending towards it, and the chin is bent or tilted towards the opposite side. We have also torsion dystonia. It's hyperkinesia characterized by painful muscle contraction, resulting in uncontrollable distortions. It can affect any muscle of the body. We talked about blepharospasm, which is painful contraction of the muscles around the eye. The main concern for this dystonia is that it can cause the eyelids to close involuntarily and for indefinite periods of time. As we said before, it can result in closure of the eye in late stages. We have myokemia, which is spontaneous, transient, or persistent movements that affect a bundle of muscles. Okay. How do we treat dystonia? We have several types of dystonia. We have generalized or segmental, we have focal dystonia, and we have young onset dystonia or childhood dystonia. In childhood or young onset dystonia, we give them a trial of levodopa or L-dopa and then anticholinergic drugs. These are the ones used in such age. Okay, what about the other types? We have generalized and we have focal. Generalized or segmental, we give them first anticholinergic drugs. If it fails, we give them tetrabenazine. If it fails, we give muscle relaxants like benzodiazepines or oral baclofen. And in late cases, we can use intrathecal baclofen. We give them an injection of baclofen in the back to cause muscle relaxation. If all these lines fail, we can use deep brain stimulation. Okay. We have the other type of dystonia, focal dystonia. Focal dystonia like blepharospasm, oromandibular dystonia, cervical dystonia, and task-specific dystonia, we give them botulinum toxin. Botulinum toxin is injected in the affected muscle. So that's why we can use it in focal dystonia only. We cannot give it to generalized dystonia because we cannot inject all the muscles of the body. So in focal dystonia, there are certain groups of muscles affected, so we can use this botulinum toxin. We inject it in the muscle. It causes relaxation of this muscle or block of neurotransmission, so the muscle relaxes. Okay, we can use it in these types: blepharospasm, oromandibular dystonia, cervical dystonia, and task-specific dystonia. We can also use other drugs like clonazepam, benzodiazepines, anticholinergic drugs in blepharospasm. We can use surgical solutions like myectomy, orbicularis ovis myectomy, and facial neurectomy. In such cases, if it is severe and not responding to other medications. In task-specific dystonia, we can give anticholinergic drugs and we use only also occupational therapy. In oromandibular dystonia, we can give them baclofen and anticholinergic drugs. Cervical dystonia, we can give anticholinergic drugs, benzodiazepines, tetrabenazine and baclofen, and if no response, we can use deep brain stimulation and peripheral surgical denervation with or without myectomy. So, the treatment here of dystonia is mainly medical, and if this medical treatment fails, we use deep brain stimulation and denervation or myectomy in peripheral surgical, but this can be only used in focal type. We cannot use it in generalized type. Okay, so this is to summarize the treatment of dystonia, either generalized, focal, or childhood types of dystonia. Thank you very much.